The first question concerns a 73-year-old woman with a loose cemented stem which has subsided, and the question asks, what effect does this have on the biomechanics of the patient's hip arthroplasty? These are the radiographs. You can see the slide on your left shows the stem before subsidence. The slide on your right shows the stem after subsidence. So the limb has shortened. The correct answer to this question is 3. Abductor complex tension is decreased, because that happens when the stem subsides. The abductors become laxer. The first and second potential answers, we call them distractors, are not correct because this subsidence does not have a major impact on hip motion. The last two answers are not correct because femoral offset is not changed and joint reactive forces would not be decreased. If anything, they might be slightly increased by this subsidence. A little bit of information concerning hip dislocation. It's the second most common reason for reoperation after hip arthroplasty currently in most worldwide registries after mechanical failure of the implants due to some form of loosening or osteolysis. The incidence is highest in the first month, but there's some continued incidence over the lifetime of implants, and about 75% or more are posterior dislocations depending on the operative approach used. The mechanism of dislocation for posterior dislocations is flexion, internal rotation, adduction of the hip. For anterior dislocations, it's typically extension and external rotation of the hip. There are a number of risk factors which have been described for hip dislocation. Some of them are demographic, and they're listed here. Prior hip surgery, female gender, elderly age, and then lower down on the slide, spastic or neuromuscular disease, drug or alcohol abuse. Operative factors do play a role in the risk of dislocation. Posterior surgical approach is clearly associated with a higher risk of posterior dislocation in virtually every study. Studies have demonstrated that repair of the capsule and reconstruction of the external rotators reduces the rate of posterior dislocation close to, but not quite as low as anteriorly based approaches. It's important to know that there are biomechanical reasons that can affect the risk of dislocation. The most common would be malposition of the components, and that will be talked about several times during this next few slides. You should know that the ideal position of the component is defined by the so-called Lewinick safe zone as about 40 degrees of hip abduction and 15 degrees of anaversion, give or take approximately 10 degrees. It's important to know that that might vary slightly depending on the operative approach used. And in general, excess anaversion increases the risk of anterior hip dislocation, while less than normal anaversion increases the risk of posterior dislocation. There are two other factors that should be noted in terms of risk of dislocation. One is femoral offset. Femoral offset, when adequate, reduces the risk of dislocation by providing adequate soft tissue tension of the hip. And finally, the femoral head to neck ratio has an effect on risk of dislocation because number one, it changes the risk of intra-articular impingement, and number two, larger diameter femoral heads create a greater jump distance to allow dislocation. The history of dislocation frequently is reported as a patient putting the hip into a position of risk for posterior dislocation. As we've just discussed, that's flexion, adduction, and internal rotation, which typically occurs with activities such as shoe tying or getting off of a low seat or toilet, although those are not the exclusive reasons. The evaluation typically begins with proper imaging, an AP pelvis film, and an AP and true lateral radiograph of the hip to demonstrate the anteversion of the socket. A secondary thing to look for would be eccentric positioning of the femoral head after the hip's been reduced to look for evidence of polyethylene wear. The next question concerns a 75-year-old person who presents late after arthroplasty of his left hip with recurrent hip dislocation. Some key points in the history: the patient does not have pain, and the patient has normal gait and full abductor strength, and there's nothing to suggest infection. The radiographs of the left hip demonstrate polyethylene wear after the hip's been reduced. The correct answer to this question is 5 in terms of management, and that is left revision hip arthroplasty for polyethylene wear. Going through the distractors, MRI imaging of the hip to exclude an abductor tear would not be particularly indicated because the patient has normal strength. There's no need to do any further tests to rule out infection at this point. And continued observation for trochanteric bursitis would not help the patient's recurrent dislocation. And finally, supervised physiotherapy in the presence of normal abductor strength and 4 dislocations would be unlikely to be of assistance. So answer number 5 is the correct answer. A little further information about treatment of hip dislocation. Non-operative management typically consists of closed reduction, usually followed by treatment with a hip guide brace or occasionally a knee immobilizer which restricts hip flexion. A spica cast would only be used in the most severe cases. And approximately 2/3 of early dislocations can be treated successfully with closed reduction. For late dislocations, the rate of success is lower. If closed reduction is not successful, most commonly revision surgery is indicated. The indications usually are after 2 or 3 dislocations of the hip, and the things that you're usually trying to solve are either implant malalignment, some other form of implant failure, or sometimes polyethylene wear, which we'll discuss more in some future slides. Resection arthroplasty is usually used as a last term resort for the patient who has recalcitrant dislocation or severe bone loss. Let's go on to the next question. The next question concerns a 79-year-old man treated with hip arthroplasty revision 2 years ago. You'll see from the slides he was revised from a resurfacing type arthroplasty to a conventional arthroplasty. He presents with 4 episodes of hip dislocation in the last 6 months, and the key point of this question is that the physical exam reveals a Trendelenburg gait, which indicates to the reader that there should be notable abductor dysfunction. Infection workup's negative, and the question asks how to manage it. Let's look at the x-rays. The x-rays show the pre-op radiograph of the resurfacing arthroplasty, followed by the picture of the patient with the conventional hip arthroplasty in place. You can see the implants are reasonably well positioned. You might suspect that the cup is slightly under-anteverted, but there are no other major abnormalities on the radiographs. The correct answer to this question is answer number 3, revision arthroplasty to a constrained polyethylene liner. An alternative answer in this day and age, I suppose, could be revision of this cup to a dual mobility implant if there was a compatible internal liner. The distractors, physiotherapy and application of an abductor brace, unlikely to help if there have been 4 dislocations. Revision arthroplasty to medialize the cup would not help. Medializing the cup actually would make the problem worse, although repairing the abductors could help with the abductor deficiency. That would probably not be sufficient. Distractor number 4, revision arthroplasty to a femoral component with extended offset. Most people would not recommend that, as it probably doesn't solve the underlying problem of the abductor deficiency. And revision arthroplasty to a large ceramic head and offset polyethylene cup, again, would not solve the problems of the abductor deficiency. And the key point here is that in the presence of abductor deficiency, in general, something more than a conventional revision is needed, either use of constraint or potentially a dual mobility implant. A few further comments about revision arthroplasty in the setting of dislocation. The key tenet of treatment is to identify the main problem and try to solve it. So if the implants are malaligned, then realignment of the implants is key. So for example, if a cup is retroverted or vertical, it should be revised to an appropriate position. If there are problems with the biomechanics of the hip, the effort is to try to solve those. So if there's inadequate femoral offset, for example, then one would try to improve the femoral offset. If there's inadequate soft tissue tension and you can't solve it with modular implants, trochanteric osteotomy may be considered. Finally, you can also, even in the presence of the other things that I've mentioned, try to optimize the head to neck ratio, because that, again, gives you less likelihood of intra-articular impingement, and by increasing the femoral head diameter, a greater jump ratio. When those measures that I've just described are not considered sufficient, then the other 2 main methods of treatment are conversion to a constrained acetabulum component or conversion to a dual mobility implant. The main indications for a constrained implant would be a well-positioned cup in the presence of severe soft tissue deficiency. Remember that constrained cups have their own disadvantages: greater risk of intra-articular impingement, greater risk of mechanical failure, greater stresses on many interfaces of the construct. So they should not be used with abandon. And conversion to dual mobility implants, very popular in Europe, becoming more popular in the United States, with at least a moderate amount of data to suggest efficacy.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.